different hats. I was the person who was leading the metadata data standards for health in 2013-14. I was a consultant to the EHR standards. And at that point in time, these were beautiful books that were lying on the shelf and they did not get implemented in the field. So this time around, when the National Digital Health Blueprint came out, we said we'll not make the same mistake. So we will sort of, go and reach out to the market. We will reach out to the people and we will reach out to the various state governments to get the standards implemented. The National Digital Health Blueprint amalgamates all the good work that has happened in the past. So in the eHealth Delhi conference, I focused a lot on the National Digital Health Blueprint. Today, I'm not going to focus on that. I'm going to focus on how we are taking it forward and implementing it in the market. So what we came out was, we had minimum viable product definitions for the healthcare delivery space. And we also have something called e-objects for the interoperability between different systems, between provider to provider and provider to payer. And then the infrastructure, if you have seen very recently, Airtel came out with a new plan that they will provide life insurance coverage. Now this is the kind of change which is going to come, and fintech, telecom is going to play a role in the last mile, which will carry it to the masses. So these are the things that we are going to ride on going forward. We wrote the e-objects in a NITI Aayog book called Health Systems for New India. Chapter 5 is a digital health chapter, and I am the co-author for that. In that, we wrote the concept of e-objects. E-objects are basically an interoperability construct using a standard called FHIR. And FHIR is a standard from the US. And we have been implementing it in India using the e-objects. I'll talk a little bit more about how this works, and in the Indian context, what are we trying to do here. We work very closely with the National Health Authority for the PMJ and also with the Ministry of Health in many ways. What we have done for the National Health Authority PMJ side is that the e-claim object is an object that is a standardized object that is being put out by the PMJ and saying to the market that if you give the claims to me in the standard format, I will give you the payments at a very short turnaround time. Because a lot of manual steps that were there in terms of submission of the claims are sort of taken care of. The standard that were put in, the EHR standard, the NDDA standards, they are bundled into a FHIR object. The FHIR is the outer layer, and inside all these standards are built in. So all the data elements that you require to submit a claim are the ones which are already built into this. The tender has come out for the Healthline platform, and the PMJ is asking for the vendors to come on board. Now we are going for consultations with the various schemes in terms of the private sector as well as the government sector, and sort of talking about this platform and the construct that has already been done. From the provider side, how will this e-object get sort of filled up, or the e-claim object get filled up? So the hospital information system, the EMRs, will have to pick up the data and populate it. Today, they don't have the wherewithal to do it. So what we are doing is we are running an accelerator program in which about 22 different digital startups and HIS vendors are working with us, including some of the government ones from NIC, from CDAC, PHFI. They're working with us to implement the standards, so to say. Now, how do you implement the standards is, today the technology has changed. You don't need the large monolithic systems that were there, the hospital information systems and so on and so forth. What you need is a very nimble technology called microservices on which the latest things work like Netflix and Uber and things like that. So we've done the design for that. And what will be the benefit? So if you look at it from the provider perspective, the provider wants payments. The government wants data to be used for policy. All that becomes available if the data is in a standardized form. From a health insurance perspective, it is that whether the claims can be handled in a short period of time and with the minimum input from their staff. So again, that gets done if it is in a standard form. From a patient perspective, it is very important that they have more options in terms of which hospitals to go to, which doctors to go to, what services that they can get. So again, patients get multiple options. All of these three different stakeholders get benefited by a one single thing, a very single change, which is the e-claim object, so to say. And it is bundled into the health claim platform, which is going to be rolled out. In terms of technology, as I was saying, it is moving to microservices. Some of the examples, Netflix. So Netflix is changing the game completely for the entertainment industry. Amazon just recently announced they're getting into healthcare. So in the US, in Seattle, they have said that for their own employees, Amazon Care has been launched. It's going to be a very short period of time before Amazon actually comes into India. So we have competition coming. And once Amazon enters, that's a 100-pound gorilla. So, we have to prepare for that. Similarly, Uber runs on a very nimble technology that, it fits into your mobile phone. You don't require that large infrastructure in terms of large data center and all that. So the technology has shifted. That's what we did. What we did was we bundled all the standards into microservices. Detailed design that we are handing over, we are giving it to the startups, and also we are in touch with STQC in Ministry of IT, and we will work together to get the software certified based on these standards. We are also working very closely with the Market Access Program of National Health Authority, and this is the grand challenge that had been announced some time back, and a lot of these new startups will come through that. They also have 20,000 hospitals that are empaneled in PMJ, so that becomes available to all the members of the accelerator, because that's the first thing that they can go and test whatever they have implemented, and be sure that working with us, private sector as well as government sector, across primary care, secondary care, tertiary care, electronic health records, platforms, and so on and so forth. We are seeing that there is a north-south divide in terms of the progress. Obviously, the vendors from the south, they are marching much faster than our North Indian colleagues. But without naming anybody, I'm saying I'm able to see that. There's another thing that I'm able to see, and that is, there is a cost of change. And CDAC is our partner for the standards, and we work very closely with them. In terms of cost of change, we thought it will be the infrastructure, it will be the large technology shift that will be the cost of change. But to our surprise, it is actually the human resource which is the cost of change. Because the old set of people that were employed by all of these different companies, they are either not willing to learn the new technology, or if they are willing to learn, there's a cost of training. And there's also a cost of sort of supporting whatever contract that they've already done. So all of them are battling with that. These are all good problems to have, because all of them are making progress, and we are moving into a paradigm where the healthcare delivery and health insurance will work together. So it's going to be very closely knit sort of ecosystem that we are trying to develop. So I'll stop with that.